I will start the meeting by just asking the audience, by just raising your hand. So you have listened to all these very interesting data on renal denervation. And so if you see a patient tomorrow who is uncontrolled and without any drugs, okay, who would offer him renal denervation? Can you just raise your hand? I'm not talking about, so nobody? Or maybe my English is not too good, or... So I ask again, who would offer renal denervation tomorrow in a patient who's uncontrolled without drugs? Nobody. Okay? One person. Sorry, you're not counting. So one person. So this means that you are not thinking the same way as your patient are thinking. And that's what we have learned from these patient preferences trial. What we believe as physicians are not necessarily what our patients believe or what they expect from us. And among people who have been looking at these type of approaches regarding patient preferences, Roland started, I think, a very nice survey where he was trying to investigate the, let's say, prevalence of patient preferences, or what are the number of patients who will prefer renal denervation over medication. Exactly the same question I ask you. And finally, you see that among this cohort of more than 1,000 patients, almost 1/3 of these patients would prefer renal denervation over medication. So this is very interesting. We are not thinking exactly the same way as our patients are, and they are expecting things from us which are not necessarily what we are ready to offer, and that's why we are here, try to fill the gap between patient perspectives and physician perspective. On the right side of the slide, you see another type of survey conducted by a Japanese team with pretty the same amount of patients. 30% of these patients would rather undergo RDN. Why is it important? Because among differences between patients, there is a concept we define as transcultural differentiation, which is that the same information, according to your culture, according to the place where you live, will not be perceived in the same way, and the answer to a question could be different from one country or from one continent to another. But in this case, we were surprised to see that finally numbers are quite similar. Now, the question I've been asking you was asked again by Roland in this survey, where you would investigate what is the driver leading physician to recommend renal denervation. And my question was not a naive one, because if you look at the way patients have asked to this question and what type of patient they believe are suitable for renal denervation, whether we are talking about referring physician or about interventional cardiologist, and the concept here is to use a Likert score. So you see here let's say the color code or the number code going from red to green. You see that for referring physician, the number of medication, or let's say for doctors in general, the level of blood pressure will probably be the most important driver for referring a patient for renal denervation. So patient, 1 out of 3, not taking any pill, rather go for renal denervation instead of adding a drug. Physician would rather refer these patients if these patients are overtreated or if their blood pressure is too elevated. Very interesting, totally opposite perspective. So there are different perspective, different preferences for considering renal denervation as a hypertension treatment option. You see here in a summary, physicians will more likely recommend this therapy for patients with an increased medication burden, a high systolic blood pressure range, probably uncontrolled. Patient would consider renal denervation regardless of current medication or baseline blood pressure status. Again, this is one type of approach, which is what we call the survey approach. It's similar to an observational study where you've been asked about what you would go for, this or that. Now, interestingly, when you dig into the perception of physician, and why I'm insisting about that, because this has a direct impact on patient preferences, is that physicians are also somehow challenged by the fact that they believe that the invasiveness of the procedure is a concern for the patient. And that's why we are talking about patient preferences, because nobody in the field of hypertension would ask a patient, would you like an ACE inhibitor or an ARB? Would you go for a calcium channel blocker or diuretic? You just prescribe the drug and you expect it will decrease blood pressure. So why are we caring about patient preferences? Probably because of this physician belief. In the field of hypertension, all doctors are not interventional cardiologists, and offering a procedure is something which is relatively new for doctors who are dealing with hypertensive patients. This brought us, and the guidelines we've been through, to the concept of shared decision-making. It's something we are familiar when you treat patients with chronic condition, heart failure or cancer or chronic kidney disease or diabetes. It's more rare in the field of hypertension, but it's popping up because of these differences in perception and because we are offering an intervention to these patients. So among all these investigations, another methodology has been used to further characterize what is driving the patient choice. And this methodology is based on a concept which is the discrete choice experiment methodology. To make it very simple, when you ask and when you want to quantify or when you want to qualify a choice, you can do it the way it has been done previously. Do you want this or that? But in fact, it's more complicated. What is driving your choice is not just yes or no, or option A or option B. You are, in your brain, finally doing what the machine is sometimes unable to do, which is having a multi-parametric approach. Okay, do you want this television or this one? Well, I want this one, but do you want from this brand or this brand? Well, do you want at this price or this price? What type of display do you want? Where do you want to buy it, etc. So when you start to think about the decision process, the simple way of asking yes or no is not able to cover what is really driving the decision process, and that's why we use this methodology called the DCA methodology. So basically, three types of approaches. An approach where you will try to quantify and qualify the decision process, where you try to mimic realistic choice, coming up with scenario and try to see which scenario is going to drive the patient choice. And this finally will allow us to do something we do in regular clinical practice, which is the benefit-risk ratio. Okay? What level of benefit is a patient expecting, and what type of price is he ready to pay to get this benefit? This is the classical benefit-risk ratio. You could also use this concept when you are trying to define thresholds and trade-offs for decision process. So this methodology will finally identify what we call attributes. So attributes is, let's say, a characteristic, for example, reduction in blood pressure, the number of side effects. And for all these attributes, you will have level among these attributes. Okay, we are talking about reduction in blood pressure, but what are we talking about? A reduction of 5 points, of 10 points, of 12 points. It's exactly what you do when you decide. You not only decide about an aspect, but also on the quantitative and the qualitative part of this aspect. And you build scenario. And here's an example of this multi-parametric approach. So you are comparing two treatments, procedure, non-procedure, but then you will see what will be the impact on the number of pills, what are you expecting as a blood pressure reduction, how long will you see the blood pressure lowering effect being carried on, the risk, you are putting the benefit and the risk item, and according to these items, you will then make a choice. Are you rather going for treatment A and treatment B? But you see that you can really play with every attribute, and you can really play with the level of attributes. So it could be 5 millimeters, 10 millimeters, 2 millimeters, 3 millimeters, and you come up with different scenarios which will then help us to understand. So among the patients, the respondents, these 400 respondents, here are the clinical characteristics of these patients who are going through this survey, through this discrete choice experiment approach. Mostly, you see here, female with a history of hypertension of at least 5 years for 40% of these patients, with an elevated systolic and diastolic blood pressure, and treated at least with 1 or 2 drugs. None of these patients, or very few of these patients, were those who were recruited in the OFF-MED trial. Now, what is finally influencing the treatment choice? What is driving the patient for renal denervation? Well, in an expected or unexpected way, what is really driving the choice is the blood pressure reduction. So a patient would go for renal denervation or would go for this type of approach if it's able to reduce blood pressure, which is more important than any other attributes here, whether duration of effect, the treatment, or the level of risk. Interestingly, when you try to see what the patient is expecting and what he's ready to accept, so the benefit-risk ratio, you see that for a quite minimal blood pressure lowering effect, the patient is ready to accept a risk which is quite elevated because, again, for a patient, avoiding taking a pill every day or optimizing his blood pressure control is something which is so important that he's ready to accept a level of risk, and the level of risk has been quantified in this approach. So in conclusion, I think that what we have learned from these approaches is that patients' perspectives are different from physician perspective. That when you really try to dig into what is leading a patient to go for a therapy, you see that finally what matters is what really matters also for us hypertension specialists, which is reducing blood pressure. That the lower the blood pressure, the better the rate of response or the higher the level of acceptance, and that the price to pay to have a minimal decrease of blood pressure is pretty high. Patients are ready to go for a therapy, that this has been taken into account in recent guidelines with the concept of patient preference, patient perspective, and shared medical decision. And that finally, I think that this approach is very innovative because it's taking into account how the future will look like. I mean, you could have exactly the same discussion with the vaccine for hypertension or for another procedure. I think we need to change the way we treat our patient. We do the diagnostic part, we offer them treatment, but we have to engage them in order to offer them the best treatment, at least the best treatment for them. And with that, I would like to thank you for your attention, and I'm open for questions from the audience. Thank you.